Good morning, and welcome to our first edition of JCEM Case Reports oral session at the annual Endocrine Society meeting. My name is Bill Young. I'm editor-in-chief of this new journal, and Adina Turku, who's up at the podium with me, is our deputy editor of the journal. I'm just going to start off by telling you a few things about the journal. We have had 250 manuscript submissions from 40 different countries. We only started publishing in January of this year. That was our first issue. We've published 115 manuscripts, either published or in the final stages of being published, and our overall acceptance rate is about 53%. So any of you that have great cases, and you'll see some examples in the presentations today, you're wondering where to submit them, I have the journal for you. So we have 4 case presentations today. Each author will have 8 minutes to present their case, and then we've allotted about 5 minutes for Q&A from you all. Then there's a microphone on the main aisle here that you can use. Following that, we'll introduce an expert that we've invited to make some comments on the case report, and then also address any questions you may have. So let's see if this is going to work here. There we go. So the 4 cases, the first one is pancreatic ACTH hypersecretion and a pituitary macroadenoma. The second is a rare case of thyroglottal duct cyst cancer. The third case is the impact of dietary cholesterol on low-density lipoprotein. And the last case is, I didn't write it down here. It is recurrent primary aldosteronism after surgery for an aldosterone-producing adenoma. So I'd like to introduce our first presenter. Dr. Chiara Batali is a medical student at Emory University, and she will be presenting on the pancreatic ACTH hypersecretion and a pituitary macroadenoma. So Chiara, if you can come up, I'll load your slides. Okay.
Thank you so much for inviting me to be here today. This is a very interesting case that we saw with Dr. Iacomescu at the Emory University Endocrinology Clinic. To our knowledge, this is the first case of ACTH, first reported case of ACTH secreting pancreatic neuroendocrine neoplasm, coexisting with a non-functioning pituitary macroadenoma. So we can start off with the case. Our patient was a middle-aged woman who presented with newly diagnosed type 2 diabetes and accelerated hypertension, who presented to the emergency room with chest pain, dizziness, and shortness of breath. She was admitted for hypertensive urgency and NSTEMI, and she was also found with severe hypokalemia on admission. Of note, she had a history of a three-month history of significant weight gain, and a 1-month history of leg edema, easy bruising, striae, and hair thinning. And family history was also significant for a pancreatic tumor in her grandmother. Inpatient workup revealed significant elevation of cortisol and ACTH levels, which prompted a referral to our clinic. And outpatient workup confirmed the elevated levels with dexamethasone testing that was also significant for no pituitary axis response. We then proceeded with a pituitary MRI, which showed a left cellular macroadenoma. As you can see, there's a hypoattenuating lesion of the left aspect of the cella. And all of the hormonal workup for the pituitary hormones was negative. At this point, we started a little bit to be suspicious for an ectopic source of ACTH secretion. And so we decided to do a little bit more of a workup outpatient. Things that we were considering is we were suspicious of of an ectopic source because of the rapidly evolving clinical manifestations, significant hypokalemia on admission, and very high levels of ACTH and cortisol levels. And so as you can see in the dynamic testing, further confirmed our suspicion with no cortisol suppression after a high dexamethasone dose, and no increase in ACTH or cortisol levels after CRH administration. Of note, chromogranin A was also very elevated at 10,400. Given the family history of a pancreatic adenoma in the grandmother, we then decided to proceed with whole body scanning. And as you can see, and with the body CT showed a solid mass in the tail of the pancreas. I don't know if you can see, okay. You can see with the white arrows, this mass was interfacing a little bit with the spleen, with stomach, and with the colon. There was some lymph node involvement. And we also found a little bit of a left adrenal nodule that was most consistent with lipid-poor adenoma. At this point, given the very high levels of cortisol and ACTH, we were very concerned for the patient, and so we wanted to resolve the hypercortisolism first. And so we gave ketoconazole first while we were waiting for further workup. In the meantime, the endoscopic ultrasound with biopsy confirmed the pancreatic NEN, and so we decided to proceed with surgery. On surgical path, we found a WHO grade 2 of a well-differentiated NEN that was positive for ACTH on immunostaining. Right after surgery, we were happy to see that the cortisol levels and the ACTH levels significantly dropped. ACTH was undetectable to the point that we had to administer hydrocortisone to the patient up to 18 months after surgery. We were happy to see that the symptoms improved within 3 months of surgery, and up to this date, which is 4 years down since the surgery, she still hasn't had any recurrence of these symptoms. The pancreatic NEN course was a little bit more complicated. As you can see here, the PET-CT scan 2 months after surgery still shows some persistent hepatic and pancreatic lesions. And so we decided to start her on lanreotide and monitor on that. 13 months, unfortunately, there was still a little bit of a disease progression, especially in the liver and in the duodenum. And so since there were a lot of somatostatin receptor-positive lesions, she was eligible for PRRT therapy, 4 doses of that. And then we also started her on octreotide, switched her from lanreotide to octreotide. 3.5 years later, we were able to see near complete resolution of the hepatic segment lesion with a decrease in size in some of the other hepatic and duodenal lesions. And on the most recent follow-up, which was in April of this year, the lesions have remained stable on octreotide. On annual MRI scans, we also saw that the pituitary adenoma was slightly smaller, as you can see on the right side, and this was 3 years after the surgery, and the adrenal adenoma has also remained stable. So some learning points from this case is that a coexistence of a pituitary and a pancreatic lesion requires dynamic testing to try to identify the ACTH, the source of ACTH production. If you look at the guidelines as of now, any ACTH-dependent hypercortisolism with a pituitary adenoma more than 10 millimeters usually prompts to a transphenoidal surgery. In our case, if we had proceeding with surgery, would not have resolved the hypercortisolism, and that would have led to an unnecessary surgery and delayed the treatment. So rapidly progressing hypokalemia, hyperglycemia, myopathy, as we have found in our case, can raise suspicion for ectopic Cushing syndrome. And BIPSS remains the gold standard for differentiating between a pituitary or an ectopic source. But in our case, that would have delayed treatment. And so that's why we decided to proceed with dynamic, non-invasive testing, whole body CT scan, and an endoscopic ultrasound biopsy that were enough for us to determine the ectopic source. And then if you look at the literature, a lot of the pancreatic NEN presentation, about 80% of them, when they present, they have metastatic disease. That makes it very hard to resolve the hypercortisolism. So in our case, this was a little bit of an exception to the literature because we were able to resolve the hypercortisolism even if there was a little bit of metastasis. And with that, I'm happy to take any questions.
Thank you, Kiera, for that excellent case presentation. If any of you have questions, there's a microphone in the aisle here. Come to the mic, introduce yourself, tell us where you're from, and ask Kiera your question. There's a mic right behind you there.
Thanks very much for an excellent case. It's amazing. I'm Anand Velasamy. I'm one of the endocrinologists based at Guy's and Thomas in London. Just a basic question. I guess we screened for MEN1 as well in this case. If there's any family history or anything. MEN1, we've screened for MEN1 or anything.
So yeah, we did have a gene panel of 36 genes, and it included MEN1, and those were all negative. So she didn't have any positive finding there. But yeah, it was we just recently checked. It was back in April of this year.
Kiara, I have a question also. I love that your intuition told you that severe Cushing's must be of ectopic source. Now, ectopic Cushing's, sometimes it's hard to find. It's not always visible on imaging. So say you had this exact case and you had the pituitary lesion, you did your other scans, but you didn't find anything elsewhere. Would you have done anything differently?
So I was actually looking into the literature, and the most cases of ectopic Cushing syndrome are actually from the carcinoid pulmonary carcinoid, and a lot of the times it can take decades to even find them or never find them. And what I was reading is sometimes just having starting them on therapy for if we didn't find anything, we would probably still proceed with trying to minimize the cortisol levels for the patient's safety, and then continue her on either PRRT therapy, or we also use the somatostatin analogs to control the disease. So it would not have necessarily, we would not have done surgery because we would have not found the source, but I think in terms of the other medical management, we would have probably proceeded similarly.
Yes, please.
Steve Winters, University of Louisville. Very nice presentation and a fascinating case, of course. So I wasn't sure why you did the CRF stimulation test. What prompted it? Was the family history or the radiographic appearance of the pituitary or some other reason? Maybe you can let us know, as opposed to just sending the patient to surgery based on the initial information.
And you said for which testing? CRS? CRH testing? Like the dynamic testing?
No, you understand?
Yeah, so the question is if you decided to do CRH testing based on what exactly we were looking for, why did we decide to do that?
Yeah, why did you do the CRF testing? Many of us might not have done that at that point in time. And
yeah,
that's a good teaching point, really.
Yeah, because we had a macroadenoma, and why didn't we just proceed in treating the macroadenoma instead of looking for an ectopic source?
Correct.
So we looked at, in my literature search, I looked a little bit at presentation of ectopic Cushing syndrome, and a lot of the time they present with hypokalemia, about 60-70%. The cortisol level and the CTH levels were 10 times or 5 times elevated. So in the literature, the urinary cortisol, when it's more than 600, strongly prompts to an ectopic source. And then the progression of the disease was in line with an ectopic source. And that's why we wanted to make sure that we had additional workup before we proceeded and doing transplantal surgery. And also all the pituitary workup, all the hormone, we checked other hormones, and those were all normal. So those are the main things we.
Thank you. Very good.
Yes, please.
Hi. Thank you so much for your case presentation. This is too tall for me. I am Melham Rabi Flori from Pittsburgh, Allegheny team. My quick question is about the dose of the hydrocortisone that you discharge the patient on. Because in one hand, you have a Cushing syndrome that we usually send them home with a higher dose just because they're used to an high dose of cortisol in the body, so you usually want to slowly taper it down for 18 months, as you said. In other hand, in your case, the patient had non-STEMI, so you don't want to give too much steroid to slow down the healing process. So what dose did you feel comfortable to send the patient home?
Let me check. I think it was one. Let me check again.
Sorry. Thank you.
It was one. I have it here, yeah. That's a good question. We had her on 20 milligrams in the morning and 10 milligrams in the afternoon, so about 30.
Just
And then we slowly taper down after about 7 months.
thank you so much.
Okay, well, thank you, Kara. You can stay right there. We're going to invite Dr. Jay Finling to come up. Jay is at the Medical College of Wisconsin, and he's an international expert on Cushing's syndrome. So, Jay, if you have a seat right here, and maybe share your thoughts on this case.
International? That sounds a little hyperbole by Dr. Young today. I think, Kara, that was just beautifully presented, and it's a wonderful and interesting case. I don't know, I had a slide. I don't know if is my slide up here?
Yeah, we can. Which slide? Oh, you have a slide.
I had a slide, but maybe it's not. Maybe it didn't get loaded in. I don't know if it did or not. Probably not. Oh yeah, this is I've said a lot of things about Cushing's syndrome in the last 40 years. Some of it was BS, but some of it actually may be true. This is the only thing I've said I'm pretty confident is true. If you've never missed the diagnosis of Cushing's syndrome or been humbled by trying to establish its cause, please refer all your patients with suspected hypercortisolism to someone who has. So this is a very challenging diagnostic and differential diagnostic problem. And of course, this case reflects the latter, that this can be a very challenging problem because of maybe incidental or non-functioning pituitary lesions, not to mention obscure, opaque pulmonary lesions. This was not exactly an obscure, opaque pancreatic lesion, but the differential diagnosis can be very challenging. Now, there's guidelines out there, but there's nothing better than common sense and some clinical experience. This is a patient who presents with prodigious cortisol excess of a rapid onset, hypokalemia, and with a very, very high ACTH level. So the likelihood that the pretest probability that this is non-pituitary ACTH secreting neoplasm is very high. I mean, it's very, very high. And the presence of a pituitary tumor doesn't really change that very much. And certainly mandates, as was done, a search for something else other than a pituitary neoplasm, and they did a beautiful job doing that. The CRH test, of course, none of you are going to be doing that again because that's gone. I don't really dispute. I think I may have done the same thing if CRH was available, because you would expect most corticotroph ACTH-secreting pituitary tumors to have some kind of response to CRH, and there was no response here. So I think that just increased the pretest probability that this was a non-pituitary or ectopic ACTH-secreting tumor. So I really endorse that approach. Now we have desmopressin, but desmopressin would not be helpful here. Desmopressin really doesn't help us distinguish pituitary and non-pituitary very well, because many ectopic tumors actually have vasopressin receptors. So I would not use desmopressin here, but CRH, if it were available, I think is a reasonable test. Now, one of the things I would have done a little differently in managing this patient, maybe it was done and not mentioned by Kara, was when patients have prodigious cortisol excess, obviously they need, and it's an emergency really, and they need either static therapy or some kind of therapy to get their cortisol levels down, which will be a bridge to some surgical procedure, in this case, obviously a pancreatectomy, a partial pancreatectomy. But during that time, you run the risk for two things. One, venous thromboembolic disease, and the other thing is pneumocystis. It's not Carini, it's something else now, whatever. PJP prophylaxis should be employed, because this is when pneumocystis may emerge, or obviously this patient's at pretty high risk for venous thromboembolism. So I usually would recommend, at least in this period of time, those additional maneuvers and treatments. I think it's valuable. So again, there are guidelines and there's common sense, and I think in clinical experience, I think this was reflected in this beautifully evaluated patient and a beautiful presentation.
May I ask a question?
Yes.
I'm going to ask a question quickly. Dr. Fingling, I think in this case, profound Cushing's is very clear that the patient might need prophylaxis for DVT and infection. But a question that comes up relatively often, and what is your trigger for initiating therapy for DVT and pneumocystis?
So it's like the smell test. I don't think the problem is there aren't any good guidelines, and but certainly in patients who have, I'm not going to give. I don't want to really give anybody a paradigm, but I would say 500 microgram urine-free cortisol or greater, I would certainly be on the lookout for a VTE, a venous thromboembolism, and probably treat the patient prophylactically for a while, perioperatively, preoperatively, and then sometime postoperatively, depending on what surgical procedure is being done. But I don't really, I think you just, again, you look at the patient. I wish there were better guidelines. There are not. Some people do it routinely. There are places that do it routinely. We don't. But in a patient like this, I think I would have provided some type of anticoagulation as well as prophylaxis for pneumocystis.
Okay, great. Jay, we have a couple questions for you. Carol?
Real quick, given the interactions between warfarin and many of the drugs that we use to treat hypercortisolism, what is your usual
Well, there certainly is with mifepristone, which I probably wouldn't use here, of course, but that's a very good question. I can't remember all these drug interactions. I can't remember with acildostat or ketoconazole. That I can't remember. Ketoconazole. But I think acildostat, I think, is all right in this setting. I don't know about mifepristone. It's very difficult to use anticoagulation with mifepristone. That much I can tell you. But I don't think acildostat is such a problem. And etomidate, if the patient's really sick and in the hospital, you can use etomidate without any trouble.
Brian?
Yeah, so a great case. I have a question actually for both of you, one I should have asked before, but is a very interesting patient. And of course, there was this lipid-poor adrenal adenoma. And one of the most common things we think about there is an aldosterone-producing adenoma. And was that at all, I guess the hypertension completely resolved? Was that ever looked at later? And I guess to Jay, would you be able to work that up in the face of such severe Cushing's?
Well, I don't know if aldosterone and renin were measured, but I know what the results were. They were both undetectable. I mean, I don't know if they were measured. It doesn't really matter, but they were both. Were they measured? Adriana, were they measured? I don't know. They were. They were undetectable. I mean, they're low. I mean, when you have hypercortisolism, you have renin goes down, aldosterone disappears. So, in fact, it's sort of an important point because I've seen patients show up in the emergency room. In the emergency room, doctors get smart and does an aldo and renin with somebody like this, and they're undetectable, and they say, "Oh, I've ruled out primary aldo." They forget about cortisol. It's like somebody seemed to forget that cortisol is also a mineralocorticoid. So, especially when it's this high. So I don't think. I think this was just my guess is this adrenal nodular enlargement was just a function of ACTH hypersecretion and ACTH-dependent nodule, and probably might be regressing now with subsequent imaging.
No, we were concerned about potentially the adrenal nodule being involved, but I think we were reassured by the imaging findings, and we just kept monitoring and seeing if any changes occurred. And then we were assured by the fact that the cortisolism resolved after surgery.
Okay, well, Kara, thank you for that presentation. Jay, thanks for the expert commentary.
This was really nice. So I have the pleasure to introduce our next speaker. It is Dr. Ashima Mittal from University of Pittsburgh Medical Center, and she will present us a rare case of thyroglossal duct cyst cancer, along with her review of the literature.
Good morning, everyone. Good morning, everyone. I'm Ashima Mittal. I work as a clinical endocrinologist at UPMC Cole Cartersport, Pennsylvania. So we had a 37-year-old male presented with painless midline neck swelling. He noted the swelling after cleaning his long-term beard. No complaints of dysphagia, dyspnea, voice changes. No history of head or neck radiation. Family history was negative for thyroid cancer. Past medical history was positive for hypertension, hyperlipidemia. Physical exam showed stable vitals. Neck exam was significant for midline neck swelling, non-tender, mobile with deglutition and trunk protrusion. No lymph nodes were palpated. Other exam was unremarkable. Lab results showed normal thyroid function test in reference range, as we can see here. Further imaging, can I move the, am I able to move the, well, okay, sure. All right. Ultrasound showed a complex solid mixed solid cystic structure measuring 4.07 centimeters in maximum dimension, and there was a 1.4 centimeter posterior nodular component, as you can see. The ultrasound did not show any nodules in the thyroid lobes or any abnormal lymph nodes. The CT imaging here shows a midline infrahyoid left cystic mass. Thank you. So here you can see a complex solid cystic mass and with thick internal septations, punctate calcifications, and there's a fluid level as well, which was all concerning for a thyroglossal duct cyst cancer. Further, patient underwent a fine needle aspiration biopsy, which was benign. Patient underwent cyst trunk procedure. Considering the concerning imaging findings and previous reaccumulation of the fluid on aspiration of the cyst, which was all concerning for thyroglossal duct cyst cancer, cyst trunk procedure was suggested. Cyst trunk procedure involves excision of the thyroglossal duct cyst, middle part of the hyoid bone, and surrounding tissue around the thyroglossal tract. The surgical pathology showed 0.9 centimeter papillary thyroid cancer arising from thyroglossal duct cyst with capsular invasion, no focal extension into adjacent soft tissue, no lymphovascular invasion or involvement of adipose tissues, large nerves, perivascular tissue, skeletal muscle or bone was seen. The staging was PT1A NX. The histology was positive for CK17, TTF1, and pancytokeratin and PAX8. Here we can see the histopathology slides. Here you can see a complex arboreal papillary architecture, and we can see the Samova bodies at the tip of the papillae. This is a 400x H&E slide which shows the nuclear features typical of papillary cancer. Here we can see some nuclear grooving, and here you can see the clearing in the center of the cell, which is basically the orphan annii nuclear appearance. Further surgical pathology slides showed denuded epithelium, that is the thyroglossal duct cyst lining, and also cholesterol clefts, as can be seen marked with a black arrow. This is a 40x H&E slide showing infiltrating ectopic thyroid glands in the fibrous tissue which are adjacent to the hyoid bone. So this was all suggestive of thyroglossal duct cyst cancer. 2 months post-operatively, we did test for thyroglobulin antibody, and as you can see, the thyroglobulin was in reference range, which is normal for the presence or appropriate for the presence of thyroid gland, and the antibodies were positive. Post-operative thyroid ultrasound did not show any evidence of thyroid nodules. At 1 year post-operative follow-up, which was around last year, thyroid ultrasound and CT soft tissue neck were negative for thyroid nodules or lymph nodes. So thyroglossal duct cyst cancer, it's the most common developmental anomaly of thyroid with a prevalence of 7% in adults. It occurs, thyroglossal duct cyst cancer occurs in approximately 1% of the thyroglossal duct cyst. Origin of the thyroglossal duct cyst cancer is hypothesized to be de novo from thyroglossal duct cyst. which is also supported by the findings that ectopic thyroid tissue was identified in the walls of thyroglossal duct cyst cancer. Co-occurrence of papillary thyroid cancer in the thyroid are therefore thought to be multifocal cancers rather than metastasis. The most common presentation for thyroglossal duct cyst cancer is a painless midline neck mass with or without obstructive symptoms. It is more common in women and generally presents in third to fourth decade of life. Most common histopathology seen is papillary thyroid cancer, followed by mixed papillary follicular thyroid cancer, and followed by squamous cell cancer. Rarer cancers like anaplastic and Hürthle cell cancers have also been reported. It is an uncommon preoperative diagnosis, as was seen in our case, owing to low true positive rates for FNAB, and this has been attributed to low cellularity of the sample due to cystic contents. So optimal FNAB is achieved by carrying out biopsy of the solid components of the cyst or repeating the biopsy after aspiration of cystic contents. There is a paucity of data on the utility of thyroglobulin washout in diagnosis of this cancer. Compared to the intrathyroidal papillary thyroid cancer, this cancer occurs at a younger age. It has higher rate of skip metastasis, which means tendency to involve lateral component lymph nodes without central compartment lymph node involvement. This is due to the thyroglossal duct cyst anatomy and the lymphatic drainage. These tumors are larger with frequent extension into soft tissue as compared to the intrathyroidal papillary thyroid cancers. Both entities are similar in terms of multifocality and prognosis. Treatment strategies include cyst trunk procedure in all cases, with or without total thyroidectomy. The thyroid cancer and thyroglossal duct cyst cancer, they coexist in up to 50% of the cases. Low risk features which don't favor total thyroidectomy include tumor size less than 1 centimeter, negative margins, absence of distant metastasis. Other considerations which would favor total thyroidectomy would include older age, that's above 45 years, history of head and neck radiation, concomitant thyroid cancer, and high-risk histopathological features, which include tumor size greater than 4 centimeters, soft tissue extension, distant metastasis, clinically or radiologically abnormal lymph nodes. The lymph node metastasis is the most common metastasis with this kind of cancer, and it's the most common site of recurrence, with mean time of recurrence being 42 months and 4.3% recurrence rate. To summarize, thyroglossal duct cyst cancer is a rare cancer with excellent prognosis. 5-year survival of more than 90%. It is an uncommon preoperative diagnosis. Post-operatively, periodic monitoring with neck, CT, and ultrasound is important in patients treated with cyst trunk procedure only, given high incidence of synchronous malignancy in thyroid gland. Surgical planning depends on detection of thyroid abnormalities clinically or on imaging, as total thyroidectomy would be indicated in that case in addition to a cyst trunk procedure. Thank you. I would like to thank my team, Dr. Jaiswal, Dr. Chetri, and Ariel for helping me put up the case. Thank you.
We invite you to ask questions about the case. I will start with a question. How often do you see hyperthyroidism, or hot nodule, within the thyroglossal cyst?
The literature I reviewed, it was never evaluated. On most of the occasions with thyroid uptake and scan, I think TSH, if it's not low in most of the cases, as it's not associated with thyroid abnormality, so I do not think that's been documented.
Right, it's rare. I asked because, as we know, hyperthyroidism, or hot nodule, would affect our biopsy. So I was wondering if you would proceed differently in those cases.
Well, in that case, I would definitely do a thyroid uptake and scan, because even a cold nodule would be suggestive of malignancy, high risk of malignancy. But I would say on the same time, I would also go ahead with a biopsy. Thank you.
Thank you. Go ahead.
Just like to share a comment and a question as well, if that's okay. Sure. So it's been a wake-up call in our department because we have missed thyroglossal cyst and cancer. So one of our surgeons is a bit pessimistic about FNAing and biopsying, especially when the ultrasound you showed had a nice solid papillary-like projection. We got to exclude a PTC. And also, just the question is, in terms of surgery, depending on the size of that tumor, would you advocate total thyroidectomy so that we have a proper monitoring thing, or it just basically, otherwise it's a lifelong nuisance, I guess, I don't know.
Well, it's controversial in literature because some people do favor, as I said, total thyroidectomy with the tumor size, especially with the presence of thyroid nodules, and in favor of better monitoring post-op. But it's a big life change. You have to be on levothyroxine or supplementation on, with your lifetime. With our patient, he was a low-risk case, and nothing on thyroid ultrasound, no imaging, no other high-risk features on pathology. So I would just risk stratify and decide.
Thank you. So now we would like to hear Dr. Brian Hogan, professor at University of Colorado, another world expert in thyroid disease.
Yeah, thank you for having me join you, and thank you for presenting that wonderful case, Dr. Mittal. That was really great, and congratulations on not doing a thyroidectomy on this patient. I'll come to that, but I guess to my colleague and friend, Dr. Jay Findling, he says there's guidelines and there's common sense. I write guidelines, so you may not hear common sense from me, but I think, as Dr. Mittal said, the thyroglossal duct cyst is very common, and a cancer in it is uncommon. I think another thing that we need to think about with these, what they did is not just rely on ultrasound, especially when you're doing surgical planning. This is a good opportunity to get a CT scan of the neck. You can do it with contrast, even if you're later going to use radioiodine, because about 4 to 6 weeks is what it would take to wash out the iodine. So I think that's a very good thing to get the CT scan. The FNA is a problem. I think getting a thyroglobulin wash is a challenge because there can be normal thyroid in there. And you can have a high. If it's low, I think it tells you something, but if it's high, I don't know if it tells you much in your biopsy. One of the studies that she had quoted in her article did look at patients who had, they did a case series, a review, a systematic review, and more than half of the cases were just single reported cases. So there just isn't a lot of literature to help guide us on this. But in that case series, there was, of all the people who had a cyst-trunk procedure only, there was 0% recurrence. There was one death, but it was somebody who had gross extra cyst invasion and had bad disease at the time of surgery. So I think we know those people when we see them, the very large lymph nodes. So I do think that you can stage them, as she just said, and not necessarily do a thyroidectomy. I would only consider it if there's something big in the thyroid that's also a cancer, or you're seriously considering radioiodine. Otherwise, I don't think you need to put, especially a young person, through a thyroidectomy who has a normal thyroid or just some small colloid cysts. So I think those are the main comments I had, but wonderful presentation.
Thank you.
Yes, so any questions from the audience, just line up at the microphone for Dr. Hagen. Here's your shot.
Hi, Hassan, Abu Dhabi. I wonder how would you follow this patient, like as far as over the next few years, imaging-wise, any biochemical workup? Would you continue to follow the thyroglobulin?
Yes, so the simple answer is yes, you can. And I mean, I would rely mostly on ultrasound now on a patient like this. How do you do the follow-up? It's similar to, I think, when we think about somebody with low to intermediate risk papillary thyroid cancer of the thyroid. Again, the guidelines don't really help us that much because we're getting farther and farther out. What I do in my own practice with those, and I would do it with a patient like this, is if everything looks good at a year, you'd maybe do 1 more 1 year, and then you can start to stretch out follow-up. And I have many patients that I call that are on my 5-year plan. I just see them once every 5 years to do things like the ultrasound. And you can get a thyroglobulin in someone with an intact thyroid or a hemithyroid. It's just difficult to interpret because, I guess you'd look to see now that it's 6 if it was suddenly 100, but if it goes up to 10, that doesn't tell you much. So it's a more limited utility, but you can get it.
And at what size of the tumor would you start to think about total thyroidectomy? I have had exactly similar patient, but with 2 centimeter PTC. I did not do total thyroidectomy. The question, at what size? 4 centimeter, for example, or larger?
Yeah, so I think you're right. You could use what we have in the guidelines, and what's in the literature about the thyroid is 4 centimeters. That's quite large. And so, I would get more concerned probably at definitely over 3 or 4 centimeters. 2 centimeters, and if there's no significant extension outside into the soft tissue, I would feel comfortable monitoring those patients. But I think somewhere between 2 to 4, getting up toward 4 centimeters or greater, I think it would be more concerning, and you might think about doing that for the purpose of giving them radioiodine.
Sure, thank you.
I'm going to apologize for this question, but I'm glad this guy shaved his beard off. That's all I can say. But so you understand. So Brian, now my experience with thyroid antedates thyroid ultrasound. So please put this question in that perspective. What role does the examination of the thyroid have in your practice in terms of nodular thyroid disease, if any?
What's a thyroid exam?
No, I mean, and I'm being serious. I mean, we did fine needle aspirations on just by palpation for years.
Yeah.
And now it's just done with ultrasound. So I just want to know, how do you put that in the exam in perspective? How do you teach your fellows? What do you teach them about the exam?
Oh, I mean, I think the exam is important. I examine all of my patients with or without a thyroid. I examine the neck. And I think it's very important. I still love, there was a study in the 50s out of the Mayo Clinic looking at autopsies. These are patients who had documented normal neck exams. And I think the largest tumor was 7 centimeters because it was deep and low, not because they don't do good exams at the Mayo Clinic. But it's because it was a deep and low. And so you can see that on ultrasound. You can see very large nodules that just are not easily palpable because of where they are. But I totally agree with you. The neck exam is very important.
Thank you. Can I have one more question? Okay. I want to ask a general question. I'm Mei-Jun Yan from Pennsylvania. I was just at the thyroid nodule conference. So they talk about using the molecular genetic testing to detect the mutations that may affect the prognosis and outcome. So my question is, as far as I know, are we going to incorporate those findings into how we manage those patients differently? So in another sense, does every patient going through surgery for thyroid cancer should have a molecular testing and using the result to detect how we guide them? This is not in the guideline. I'm just asking, are you going to put it into the next guideline? Thanks.
Well, I can guarantee you I won't put it in the next guideline because I'm not on the committee. So I don't know what the guidelines, they definitely will be talking about this, I'm sure, in the guidelines. And you bring up a very good point. And this comes back to, I'll say, for this type of patient, there just is not molecular data on thyroglossal duct cyst carcinomas. I mean, so we just don't have enough data to say. I would suspect it's probably similar, but I don't know, to a nodule in the thyroid. Molecular testing is really good for diagnosis. It's actually getting really good for therapeutics because now we have a lot of these actionable targets that we can use in patients with advanced cancer. I think it's still in its infancy in prognosis. Partly, we have some good prognostic markers like TERT, P53, maybe PIK3CA, things like that, but we don't have any data yet to say, what do you do differently with those patients? you worry more? You know, do we need some outcomes data, I think, to make that prognostic testing more useful? So in a typical person who has a small papillary thyroid carcinoma that comes out, I don't think they need molecular testing in that patient at this point. Until we get better data with our prognostics, I don't think we have to do that routinely yet.
Well, Shima, thank you for that presentation. Brian, thank you for that expert commentary. Okay, our next presenter is Dr. Michael Porter. He's an endocrine fellow about to graduate from Vanderbilt University in Nashville. And the title of his presentation is Impact of Dietary Cholesterol on Low-Density Lipoprotein, Lessons in Absorption and Overconsumption. Michael.
Hello, good morning, everyone. Before I begin, I just want to thank the Endocrine Society for this fantastic opportunity. I want to thank all my mentors, some of which are here from Vanderbilt, for my outstanding education over the last couple of years. And then I specifically want to thank Dr. Melissa Wellens, who was a big part of this case for me and a big help. All right, so I'll get into it. First, just some quick background. So the impact of dietary cholesterol on lipids has long been a debated topic of both scientific study and, as we all know, of layperson media. Eggs are often the example cited in this debate, as they are a rich source of dietary cholesterol without comparative high levels of saturated fat, of which the effects of LDL are well established. Eggs specifically have been investigated looking at both direct LDL effects and cardiovascular disease risk with mixed results over the years. However, recent research investigating these discrepancies and controversy supports inter-individual variability in LDL response to dietary cholesterol as a potential explanation. So now jumping into our case, we have a 58-year-old woman who presented to our lipid clinic in August of 2020 for management of hyperlipidemia. Her past medical history includes GERD and long-standing ulcerative colitis. Of note, she had no known prior history of cardiovascular disease. However, atherosclerotic changes were incidentally noted on an abdominal CT in March of 2016. Her past surgical history is notable for a total hysterectomy and bilateral oophorectomy at age 37. Her medications include Entyvio every 8 weeks, and this is a medication she had been on for the ulcerative colitis since approximately 2015. Omeprazole, gabapentin, and meclizine as needed. Also of note in relation to her medications, she was on estrogen replacement with an outside provider from approximately age 37 at the time of the oophorectomy until age 55. Her family history is noted for coronary artery disease in her father with a MI in his 60s. Her mother has a history of hypertension and also mixed hyperlipidemia, and then she has a grandfather who also has a history of coronary artery disease. Social history is notable. She's a lifelong non-smoker. She has no alcohol or recreational drug use. She typically walks for exercise, and this occurs at varied frequencies, but up to 30 minutes daily. So this case takes place over several years of historical data review. So the first lipid panel we had in our file was in 2015, and you could see her numbers there. Some overall numbers we all might see with regular patients that come through the door. In 2017 was her next lipid panel, and the repeat LDL at that time was 255. And that jump prompted treatment at the time with her primary care provider with atorvastatin. However, after shortly being on atorvastatin, she experienced dermatitis, actually saw a dermatologist for this, and because medication reaction was favored as the etiology for the reaction, she discontinued atorvastatin, and no other statin therapy was attempted after that. And we now fast forward to January of 2019. She's been off of atorvastatin. Her LDL at that time is 162. She reports throughout these years, from approximately 2015 until this time, she had been consuming a very strict vegan diet. Her weight ranged between 93 and 103 pounds throughout this time period. And then later in 2019, sometime in the late winter, early spring, from what we can gather from her history, she began incorporating 9 eggs per day, equivalent of 1,600 milligrams of dietary cholesterol into her diet. She denied consumption of any other animal products or notable cholesterol-containing foods. On our next lipid panel, in August of 2019, we have an LDL of 378. Lipoprotein little a, I wanted to include this. It wasn't the focus of the case report, but this was also measured, and it was significantly elevated to 176. She, because of COVID pandemic and some other patient-related factors, she was kind of lost to follow-up from the time of that lipid panel in 2019 until then August of 2020, where she had a repeat lipid panel with an LDL that was now at 420. So that is the point where she saw us at Vanderbilt. And on this evaluation, she was advised, after gathering information about her dietary consumption, to limit her egg yolk to approximately 4 per week from the 9 per day, which would be approximately 100 milligrams a day of cholesterol from the 1,600. On the subsequent visit following this counseling, her dietary recall included transition from whole eggs to now using egg whites. And her additional intake was very limited. She decided to take olive oil, beans, and potatoes. And as I wrote here, she was with a long-standing history of ulcerative colitis and GI-related symptoms. She cited that as the motivator for such a rigid diet program. We then saw her in October of 2020 without addition of lipid-lowering therapy at this point, or other notable lifestyle changes, and her LDL decreased from 420 to 204. Then in January 2021, LDL had decreased further to 130. And as I said, medications, both in relation to lipids or for her other conditions, had not changed at this point. Her BMI was stable, and her exercise routine was stable as well. We then saw her again in August of 2021. LDL at this time was 142. So at this point, ezetimibe was added to her routine. And in 4 months following the addition of that medication, her LDL was 103. We then saw her a year later, and with that same routine, her LDL had gone all the way down to 61 at that point. And again, from the history we can gather, both from the chart and from her patient encounters, there have been no other changes to her medications or her nutritional intake. And then here, I wanted to include a chart. I know the numbers are a little small, but those are all her lipid panels that I reviewed over the years. And I wanted to put it into context of her total cholesterol, her triglycerides throughout this time, and her HDL cholesterol with all those LDL fluctuations. And there's the LDLs that we spoke about. So I'm actually just going to leave this up as my last slide. The two main focuses of my discussion when putting this case report together was thinking about LDL response, obviously, to dietary cholesterol, and the potential for hyper responders, as was seen in this case, to the dietary cholesterol, as well as thinking about the role of her inflammatory bowel disease and what role that might play in this. From what we can tell, as I said, her medication was stable. Her disease process was relatively stable over these years, and so we do not believe that this played a significant role. The medication that she was on was, to my knowledge from the literature review, did not have a significant association with lipid abnormalities. IBD as an inflammatory process itself actually creates what I saw often referred to as a lipid paradox, where when the disease is active or in an inflammatory state, actually having a decrease of LDL, with then a increase when treatment is initiated and inflammatory state goes down. The response to that treatment can vary based on the type of medication used, but none showed the significant jumps that we would see with her. So that's my case. I'll open it up to questions. Thank you.
Yes, Carol.
Nice presentation, thank you, and a very interesting case. I have two questions. One is, one's a statement. Have you done TSH levels with every LDL just to make sure that there wasn't any issues with that being
That's a great question. The more recent lipid panels, yes, from when we had been following her, we do have normal TSH values. I can't speak to the years prior to that, prior to 2020. I do not believe, I know she had always had a normal TSH when it had been measured, but I do not know if it's been checked each time.
So when she was 420 or those very high numbers, did you have a TSH level at those times?
Yes.
Yeah, because I think it's important with her inflammatory disease. She's at higher risk of other autoimmune diseases, and thyroid would be obviously the most common, and it can come and go, with silent thyroiditis and not be aware of it. And
Absolutely.
then the second is more of a point, and that is the fact that she over-responded to ezetimibe. I mean, 18% reduction is average, and she had more than a 50% reduction, suggests that there's something unique going on in her cholesterol absorption itself.
Yeah, that was kind of, while we were figuring out what was going on exactly just with these jumps with the dietary changes, once we saw that, that really pointed to us and led me to put this together to think about hyper-responders.
Great. Thank you very much.
Thank you.
Please.
Satish Parthasarathi, one of the endocrinologists from Sussex in the UK. Excellent presentation. Just a little concerned about her BMI being 16.1, right? So I assume you have probably screened her for eating disorders. And I suspect, because we see this in clinical practice, that most of the patients with low BMIs, eating disorders, have abnormal lipid profile. So there might be a link to that. So did you look into that as well?
Yeah, that's a great point. I know anorexia nervosa can definitely be associated with lipid abnormalities. She was screened in a clinical sense from gathering history, and did not have any evidence from our perspective to have an eating disorder, but it's definitely an important point, and thank you for bringing that up. That is something we should be aware of.
Caroline.
Yeah, Carolyn Becker from Boston. Thank you. Very interesting case. Gives me a new insight about eating eggs. But I'm just, and this is off the topic, but why did this young woman have a TAH-BSO? Was that related to her ulcerative colitis or something? Because you didn't mention the cause. She was very young when she had that. Thank you.
Yeah, I apologize for that. I don't know offhand the details surrounding that procedure, so I don't want to speak to what I think it's related to without having the actual records and information related to it. I apologize, I'm not sure about that, but that is an important point, and was also something we discussed in the case, was thinking about when she came off estrogen replacement as a potential influence on changes we were seeing. Thank you for bringing that up. And I did have eggs this morning, so hope it's not too much of an influence.
Hi, Marina Litvin, St. Louis. Interesting case. Thank you for presenting. I also had a question about her BMI and if in any way it could correlate to disease flares and how that could affect her nutritional absorption and also LDL absorption from her diet. That was just a question because the BMI is strikingly low. Is her IBD considered to be under control? And just a second comment that with a low BMI, early hysterectomy would have concern, of course, for osteoporosis, just as an aside. Thank you.
Yeah, thank you so much for bringing that up. I'll let our expert speak to that a little bit as well. But her disease course, at least from review of the GI records through her appointments, was stable from our perspective, and she was on the same medication throughout that time.
I just want to know what happened with the LPA. Yes, what happened with this?
I know I wanted to include that because it's an important point of the risk that she's at and driving our decisions. I focused on the LDL here, but for now, with the LDL being 61, we are sticking just with the monotherapy. I know I could also let our experts speak to LP little a modulating medications that are in the pipeline and whether other medications would have played a role for her just because of that value. I let our experts speak to that.
Michael, thank you for addressing all those questions. I'd like to invite our expert up now. It's Dr. Vinay Simha, who's a colleague of mine at Mayo Clinic in Rochester, Minnesota. and he's a true lipid expert. Any questions you have about lipids, come to the microphone after he's done with his comments.
No. Actually, I'm the expert. Today I'll just be a storyteller, okay? So I'll just tell you 2 stories. And the reason why I'm going to do this is this. I mean, all of you have admired at Michael's presentation. It is so good. But I'm sure there are at least some of you in the audience who are thinking, but what's the big deal? I mean, somebody eats a lot of cholesterol, their cholesterol goes up, isn't it obvious? The thing is, it is not. And these are the 2 stories I'll tell you. So lipid experts have been baffled at why this doesn't happen. And this was way back in the 1930s. So there is this person called Schonheimer, and even the great Goldstein and Brown actually allude to his work. Schonheimer's bottle to scabs Milatel, that's one of their famous papers. So here's what Schonheimer did in the 30s. So he took the bottle. So he had these mice that were housed in a flask, and they would be there for 4 weeks. And then he would that's where they would live for the next 4 weeks. And he changed the dietary composition. He gave them bread with different amounts of cholesterol. And at the end of 4 weeks, all the mice were sacrificed. They were just turned into a slurry. And he measured the cholesterol in these flasks. And what he showed was that it didn't matter how much cholesterol he fed them. At the end of 4 weeks, the amount of cholesterol in that flask was constant. So organisms have evolved to keep their cholesterol levels constant, no matter whether they get a lot of cholesterol in their diet or no cholesterol in their diet. And then now fast forward to, this is in mice. And then in the humans, so there is this another very celebrated case report in the 1990s, I think 1991, and this is in the New England Journal of Medicine. So imagine, case report in the New England Journal of Medicine. And that's because, when you said the 9 eggs, and then all of you gasped. So the title of this case report is this: Normal plasma cholesterol in an 88-year-old man consuming 25 eggs a day. So that's what you need to do to get a New England Journal of Medicine. So this guy, he had a compulsive obsessive disorder, so he would eat an egg every 20 minutes when he was a soft-boiled egg. And he didn't do it for any health reasons. He said he just couldn't help it. And he was studied at I think it was in Denver, Colorado. And what they did was, so they did all these balance studies looking at cholesterol absorption, and then they looked at bile acid synthesis and endogenous cholesterol synthesis. And what was noted was there was a marked reduction in cholesterol absorption. It dropped down to about 20%. And the bile acid synthesis went up more than double. And of course, the endogenous cholesterol also goes up. So this is what happens in most of us. I mean, it's never going to be completely normal like this, but dietary cholesterol has very little influence on our circulating cholesterol in most people. And that's why now the guidelines actually consider that dietary cholesterol is not a nutrient of concern for overconsumption. Okay? But I think that pendulum has swung a little too far in the sense, when this guidelines came out, I think in 2017 or something, the Time magazine in its cover had this thing, it said, eat more butter. I think it was a complete misrepresentation. So, that's saturated fat, this is cholesterol. But then even here, I think we must not miss the point that overconsumption, there's something bad in that word, okay? So overconsumption is not good. Number one, as he said, clearly there are some people where this doesn't happen. And this probably has to do with what he was alluding to in the fact that these are hyperabsorbers, and that's why they have this fantastic response to Zetia as well. Presumably, they have polymorphisms in NPC1L1. So that's the protein where Zetia acts, and that's the protein that regulates how much cholesterol we absorb. So most of us, we down-regulate this when we eat a lot of cholesterol, but presumably some of us cannot. And those are the ones who are hyperabsorbers. And so we should be aware of that. So at the Mayo Clinic, we now have, I think, about 15 of these people who went on a keto diet, and then their cholesterol went up. So one of our cardiology fellows actually presented this case series in a preventive cardiology thing. And we are now trying to do whole exome sequencing and try to find out whether they truly have this either NPC1L1 or some other dysregulation in the bile acid synthetic gene. So I think that's important. And I think to me, the take-home point is this. Whenever somebody goes on any crazy diet, make sure you check your cholesterol immediately. Don't wait for 5 years before you do that. Okay.
Thank you for the explanation. That's very interesting. I do have a similar patient who tried to change diet to control sugar. So she ate peanut butter mixed with avocado every day for lunch for several weeks. Then we got a lipid check. Came up LDL is much higher, like a 40% increment. But at the same time, HDL was higher too. So if you look at if you use the LDL to HDL ratio, actually ratio was pretty good, a little bit 2 point something to 1. So based on that, LDL to HDL ratio is low. I didn't recommend any changes, just to say maybe eat less, using common sense. So my question is, one is, do you use the LDL to HDL ratio to incorporate in the assessment or management? Second is, right now, okay, we got lost. So if patient asks you, how many eggs a day can I eat? How should I answer that?
Yeah, the first question is easier. No, I don't look at HDL. Okay, so I don't think the ratios are useless. High HDL does not necessarily mean that you are at lower risk. So no, I think a high LDL, we should still respect that. And then in terms of how many eggs to eat, now that's the big thing. So now even though it is true that in the vast majority of the population, it probably doesn't have a significant effect, it still increases it a little bit. And there is good data showing that in people with diabetes, it increases the risk of coronary artery disease and of strokes. And then there is a more recent publication, I think this one was they looked at AARP data or something, and there they showed that yes, it does actively increase the risk. Overall, I think moderation is still pretty good. I think, we don't have to, the old NCEP said you should be less than 200 milligrams per day of cholesterol for the step 1 diet. I mean, I don't know, what you said, 4 eggs a day. I mean, if somebody, I think the best thing is this, you should be moderate, but if you're not, then you should check. And if you're one of those who's like, this guy ate 25 eggs and nothing happened. Okay? So I guess we'll have to monitor it, but in general, an egg a day should be fine.
Again, I apologize for this question because I don't know anything about lipids, but that was a great presentation. What about alcohol? Did you mention alcohol consumption, this lady?
Yeah, in her initial history, I did mention briefly just that she denied any alcohol consumption.
None.
Yeah.
Okay. And then my question is, why is the HDL cholesterol? It doesn't change it at all. Why does she have such a high HDL cholesterol?
I don't know why she had, but eggs are known to actually increase the HDL cholesterol. In fact, that was the argument that was made, that even though the total cholesterol goes up, it goes up in both the LDL and the HDL fractions. Okay. So presumably it increases CETP or one of those other things. Yes.
Dr. Simha, I also have a question for you since you are the world expert in lipids. So I have a personal anecdote. When my husband and I had routine labs applying for health insurance, life insurance, I should say, my husband was found to have really low lipid levels to the point of where HIV patients or more nourished patients have. So I was going to ask you, is there any downside to having really low cholesterol levels? And do you think this is connected with, say, for instance, him forgetting a lot of tasks that I give him? And should I ask him to start to eat a lot of eggs?
No. Okay, yeah. So no to all of them. Okay, number one is great. So and presumably I think he has. So check the cholesterol levels in his parents. So this is very common. So there is this entity called familial hypobeta-lipoproteinemia. Okay, so they usually have, this is an autosomal codominant condition. So you will always have low ApoB, and therefore you cannot make adequate amounts of ApoB containing particles. They are at risk for fatty liver disease. Okay, that's the only thing to worry about. But cardiovascular, no, they are protected. So most certainly no. No memory.
If we have time, I was just curious, Dr. Simha, on the question related to the Lp(a). If you have any comments or thoughts.
That will need a session.
Okay.
Yeah, here's the thing. Though I would have loved to measure his, because traditionally we said Lp(a) is completely independent of lifestyle factors and diet. So, but in somebody like this, I would still be curious to see what happens to the Lp(a). Thank you.
Okay, Michael, thank you for that great presentation.
Thank you so much.
Renee, thank you.
Thank you, Michael and Dr. Simha. Our last case will be presented by Dr. Mitsushiro Kometani from Kanazawa University in Japan, and he will present a case of recurrent primary aldosteronism after surgery for KCNJ5 harboring aldosterone-producing adenoma.
Good morning, everyone. So I would like to thank Bill Yang and everyone for giving us this opportunity to present work. So apologize at first. So I'm good not speaker in English. Sorry. So today I would like to introduce two cases of recurrent primary aldosteronism more than 10 years after adrenalectomy and with a KCNJ5 gene mutation. So this is case one. So case one is a 52-year-old woman who aged 29 at the first presentation. At that time, she had hypertension and hypokalemia. So she was diagnosed as an APA in the right adrenal gland. So after total adrenalectomy, so her blood pressure and serum potassium level are normalized. Next, this slide shows the at first presentation data. So she had the hypokalemia and the high level of ARR. So abdominal computed tomography showed the right adrenal tumor with a 20 millimeter. So the confirmatory test, two different confirmatory tests confirmed PA for her. So this is a non-ACTH stimulated adrenal vein sampling. So ABS showed the overproduction from a right adrenal gland. So she's performed the total right adrenalectomy. After that, so 1 month later, so post-operative outcome. So she her potassium level normalized and confirmatory test after surgery. So performed the furosemide upright test, restored the renin reactivity, and rapid ACT stimulation test showed a decreased PAC. So she stopped going to the hospital. But at the age of 52, she began to present hypertension again. So medical examination revealed the high level ARR. So the laboratory test showed the high level of ARR, but she had no hyperkalemia. So at the age of 52, abdominal CT showed the contralateral side, left adrenal gland, so left adrenal tumor. So we evaluated by the confirmatory test. So two different confirmatory tests confirmed the PA. So, but she has no willingness to the surgery. So she is now the medication now. So case two, a 50-year-old man. So she has so as a first presentation. When he was 47-year-old, he had hypertension and hypokalemia. So he was diagnosed with APA in the left adrenal gland. So after adrenalectomy, his blood pressure and normalized. At the first presentation, his laboratory data showed hypokalemia, and abdominal CT showed two tumors in left adrenal gland, the 14 and 13 respectively. So furosemide upright test showed the confirmed PA. So this is at the first presentation of ABS. So ABS showed the insertion into the right adrenal vein is unsuccessfully, but from left adrenal vein is or PSC is high, so diagnosing the left overproduction from left adrenal gland. So he was left total adrenalectomy. After that, his blood pressure was normalized and no hypokalemia. But 2 years later, at adrenalectomy, the laboratory data showed no high-level ARR. But 4 years later, he has hypertension again. And in retrospect, the laboratory data showed a high-level ARR from the 5 years later. So at age 65, so CT showed the right adrenal gland tumor. So he was referred to us. So laboratory data showed a high-level ARR, but he has no hypokalemia. At age 65, abdominal computed tomography showed a left adrenal tumor, and we performed the capillary challenge test. So this test showed the recurrence of PA. So very fortunately, I could get the specimens at that time. So the histopathological analysis showed the case of case 1 and case 2 are both adenomas. So recently, the APA-specific gene mutation are reported. So the specimens from that time, so we conducted the gene mutation analysis. So surprisingly, so the tumors of case 1 and both tumors of case 2 had G151R mutation of KCNJ5 gene. So recurrent PA is so very rare, and the recurrent PA occurs on average of 7.4 years after treatment. So, it's ipsilateral recurrence occurs after ethanol injection and partial adrenalectomy. But recently, after total adrenalectomy, the contralateral side recurrence is occurred in PA. The prevalence of somatic KCNJ5 mutation in APA, so surprisingly, so in East Asia, KCNJ5 gene mutation is very, the frequency of KCNJ5 mutation is high in East Asia. So it is possible that APA with KCNJ5 mutation may occur in the contralateral adrenal gland left after surgery under similar circumstances. So same as right or left adrenal gland. And so we think that the contralateral adrenal gland became the same conditions in different time scales. Its learning point, so the driver genes of APA have been detected in previous studies. So it is important to follow up the patients with driver gene mutations. So the frequency and the type of PA recurrence differ based on the treatments. So it is necessary to investigate the association between PA recurrence and treatments. So there are no specific guidelines for the management of patients with recurrent PA. In summary, we here in the presented 2 cases of recurrent PA after adrenalectomy. So gene analysis revealed the mutation in KCNJ5 gene in the rejected tissues of APA in both cases. So recurrence of PA is extremely rare. The mechanism underlying has not yet been elucidated. So based on our experience, so we need long-term follow-up of patients with APA after treatment. Thank you.
Thank you so much. If there are any questions about these two interesting cases, please address them from the microphone. I can start with one question. So there is at least one study that suggests that patients with KCNJ5 mutations have a good prognosis after surgery. In other words, KCNJ5 predicts cure after surgery. What can we learn from your case? I think most PA experts, and we'll hear from one of them today, believe that cases with an aldosterone-producing adenoma who don't cure might have satellite lesions that harbor calcium channel mutations. So I was just wondering if you stained all of the blocks from the patient, not just the one with the largest tumors, and if you saw any other smaller CYP11B2 positive areas.
Sorry, so we can read to this cases, so we can't the CYP11B2 immunohistochemical analysis. Sorry, so this case one, so with from by Dr. Sasano, but not using the CYP11B2, so very old case.
Very interesting. It would be nice to go back and look in the tissue.
Thank you for that presentation. My name is Gadmi from University of Minnesota. Routinely, we don't check KCNJ mutations right now, but based on these findings, is it recommended to check KCNJ mutations routinely in patients with APA for close monitoring? Or even should we check this beforehand? So that we can advise patients regarding recurrence down the line. Thank you.
So I think so. In Asia, so in Japan, so KCNJ5 mutation is so very high. The frequency of KCNJ5 mutation is very high. So in our institutions, 58% of APA is KCNJ5. So, but now, so we perform the next generation sequence of the APA. So I think so. We should check the gene analysis of APA. Okay.
I can maybe add a little bit to this answer. So these aldosterone driver mutations are somatic mutations that will only be present in the tissue, in the tumor. So you cannot find the mutation in itself by testing the blood. But there are emerging biomarkers of genotype-specific APAs. For instance, for KCNJ5 mutated APAs, we most commonly find hybrid steroids that are elevated, 18-hydroxycortisol, 18-oxycortisol. So you could potentially use those as prognostic factors, but we are not far along enough to recommend that routinely. So thank you so much. I think now we would like to hear from my dear mentor and colleague, Dr. Bellarani from the University of Michigan, who has done major work in the genetics of aldosterone-producing adenomas.
Thanks. I'd like to thank the Endocrine Society for allowing an endocrine researcher to join the clinician team. So I think we're in safe hands in case I go off the rails. I did want to sort of take a step back with these cases and say these are extremely rare cases. And if you consider primary aldosteronism and work a patient up and have AVS done, most of your patients are going to have bilateral disease. And you're going to have part of them that lateralize. And of those, some are going to be well lateralized like these, and then you're going to remove an adrenal. Now, more common than recurrent primary aldosteronism is partial cure, where Adina is doing work. There's people around the world trying to do work to limit the number of adrenals that are removed that are going to only end up with partial cure. So that's much more common. This is extremely rare. I talked to Dr. Young before, probably maybe 1% where you actually have cure and later you have recurrent disease. So my lab works basically on defining the genetic mutations, but also looking at the cellular origins of primary aldosteronism. And as Adina mentioned, the new guidelines suggested consensus recently suggested that in pathology you look with immunohistochemistry for the terminal reaction of aldosterone production, aldosterone synthase, and if you see a singular nodule that stains with aldosterone synthase, that's an adenoma, there are studies now predicting that that's more likely to end up with a long-term cure. But if you see an adrenal with multifocal disease, you anticipate that the other adrenal may have such multifocal disease and you may have only a partial cure, or you may have recurrence later. So that's kind of the researcher's view of what's changing here. There's another unique feature, especially with the first case, that is early age onset PA as well. So that's much earlier than most cases, so another rare thing. So what happened in these two individuals? It's very likely, KCNJ5 mutations, as Dr. Montecani mentioned, is extremely common in the Japanese population. In our study with Sendai, we were reaching 90% levels of KCNJ5, whereas in our US population, much more around 50, so that it's very common. Right now, post-surgical diagnostic analysis of the mutation probably is not very helpful, but as Adina mentioned, these tumors uniquely produce a series of steroids that will help someday decide if you've got that mutation, you're more likely to have a very good biochemical and clinical response to surgery. So beyond that, are there other topics you'd like me to cover? This workup, the lateralization was so clear. The Kanazawa group is excellent at working up with PA, and these cases they did exactly what you should do, and that is remove the adrenal and note a long-term period where there was no PA, where the patient was healthy. So that looks like looked good.
So can I ask you quickly, what do you think now that all of this research is emerging? Most of the PA cohorts only had very short-term follow-up. Should we now consider, with the new guidelines being under revision, to propose follow-up for everybody who has surgery for lateralized PA? I don't know what the frequency would be, but should it be long-term, 10 years, more, lifelong?
We can get Bill to weigh in on this, but right now, you could probably tell us, when you send a patient home with biochemical cure, is that patient need follow-up more than anyone else?
So, as Bill mentioned, the recurrent PA is very unusual, but it does happen. We haven't analyzed the cases as well as you have, but presumably they are recurrent somatic mutations in the contralateral adrenal. So Bill's asking, well, what should we do? How should we follow these patients? And Adina's bringing up, should this be part of the new guideline? I think first of all, we proved they were cured, right? We measure aldosterone renin right after surgery. We measure it 3 months after surgery, 6 months after surgery to show that they're cured. And if they become normotensive, then that's probably our best marker of recurrent disease, 5, 10 years, 15 years later, like these cases showed. So chronic rechecks of blood pressure would make sense to me rather than continue to measure aldo and renin every year. Whereas if you have persistent hypertension, I think that's a little more difficult because then we don't have that marker for recurrent disease. And honestly, I'm a bit on the fence whether these patients should have like annual aldo and renin measurements. I don't know what the right answer is. Bill, I do have a question for you. So these KCNJ5 mutations, what's the deal with position 151? Why does it seem like, because there's only a couple, right? Is there something fragile at that point, or why is this more common?
Well, it relates to another research area we're looking at. It's not only a race difference in acquisition of those mutations, but there's a sex difference, with women predominantly getting KCNJ5 mutations and men leaning toward L-type calcium channel mutations. So we're doing deep sequencing now across samples from women who've got the KCNJ5 and men that don't, that have alternative mutations, to see if there's some sort of alteration in DNA repair that might help explain not only the KCNJ5, but look at other SNPs to see if there's differences there, to better understand the sex difference, which will also help us maybe better understand the race difference in acquisition of mutations at that site.
Dr. Finley.
Since the guidelines were mentioned, when do you think in clinical practice clinicians should look for example, I think Adina mentioned CYP11 beta 1 immunocytochemistry on the tumors, or doing genetic profiling for KCNJ5. I mean, where has this leaked down to clinical practice yet, or is this still mostly research tools? Can you comment on that?
Well, there was a consensus organized by Martin Reinke and Tracy Williams in Munich, with a number of pathologists and endocrinologists and researchers included. And the bottom line from the consensus was really to push the concept that pathology departments should start using the CYP11B2 aldosterone synthase immunohistochemistry to localize expression. And if it's a singular nodule with no other multifocal disease, small studies are suggesting that those patients are more likely to have long-term cure. But is it for guidelines yet? I don't think so, but I highly recommend, if you have access to pathology fellow department and can get them to do the immunohistochemistry, do it. If not, there are many groups in the U.S. now that have incorporated it where it can be done.
And with that, we are out of time for this session. I want to thank Mitsuhiro and Bill for those excellent discussions. Thanks to all the presenters.